Now let's start with upper limb trauma. With the basics sorted, we will start with the trauma that occurs in the upper limb. Now when I say upper limb, I'm talking about everything that starts from the clavicle and ends at the tips of the fingers. The first thing I want you to understand that is common in upper limb trauma or injuries is that these injuries usually occur by a common mechanism. Now what is this common mechanism? This common mechanism is falling on an outstretched hand. Now what do you mean by this Foosh injury? Foosh means falling on an outstretched hand. Okay, it's an acronym. So Foosh injuries are basically when you fall forwards or you fall backwards or you fall on the sideways. Wherever you fall, your body will automatically, it's a defense mechanism, throw out its hand to protect your head, which is apparently the most important part of your body, not your heart. Right? Anyways, so when you fall, your upper limb is outstretched to protect your head. And this is what causes the injuries of the upper limb. So everything that we are going to talk about in upper limb injury has a common mechanism, that is falling on an outstretched hand. Now, obviously, different injuries or different fractures will have some specific or unique mechanism of injury that we will discuss. But ये तो common है. This is common and this will work for everything. Now we'll start with injuries starting from clavicle, then move on to the shoulder, then the proximal humerus, shaft of the humerus, distal humerus, elbow, forearm, wrist and carpal bones, and then finally move on to the hand. Okay. Now the key that I want you to pick up throughout all these injuries is how to make the diagnosis with two things. First, clinical diagnosis. Second, radiological diagnosis. Only when you're able to do these things, make the diagnosis either clinically or radiologically, everything else will matter. Because now the recent trend of the exams is to basically first make the diagnosis, and based on that diagnosis, they will either ask the treatment or the complications or something else. So you have to be good at making the diagnosis. So you have to be good at radiological diagnosis as well as clinical diagnosis. Okay? Now, we'll start with the first bone, that is clavicle. Now look at this. This is supposed to be your clavicle, right? My left clavicle. Now, there are many unique things about this clavicle that you should know, and I'm assuming you already know thanks to your knowledge in anatomy. But I will quickly breeze through them and revise it with you and see if you know this. And I will tell you why those points are relevant in terms of orthopedics. See, first of all, this is the only long bone that is horizontally arranged in your body, right? And most of the long bones, in fact, all the long bones, they ossify in cartilage, right? And chondral ossification. First, there is a cartilaginous structure which ossifies and then becomes bone. But this is the only long bone that ossifies in membrane. Okay, so there is a membrane, and underneath the membrane, the ossification occurs. Something like your skull and ribs. Clavicle is a long bone that ossifies in membrane. Now, the third thing I want you to recall from your anatomy is this is the first bone to start ossifying and the last bone to complete its ossification. So first bone, when does it start ossifying? Wait, listen. I can imagine now. I can see you writing the notes down. Don't worry, listen. I have designed the module in such a way that everything that I say is written on the PPT. But I will make you understand first. I want you to listen and grasp what I'm trying to tell you. Okay, then I will show you the slide where everything is written. So what you can do is pause and then write down, make your beautiful, wonderful, amazing notes. Okay, but right now, pay attention, listen to what I have to say and understand. Everything is there, friends. Trust me, everything is there. Okay, now. So it's the first bone to start ossifying and the last bone to complete its ossification. First bone to start ossifying means when does it start ossifying? It starts ossifying on the 5th intrauterine week. Okay, and when does it complete ossification? Somewhere around 21 years, 22 years, 23, 24 years, around that it completes its ossification. Okay, another important point is that it is the only long bone that has two primary centers of ossification. Primary centers of ossification are intrauterine centers of ossification, and usually the long bones have one. But this is the only long bone that has two. Apart from that, something that is very obvious is that it is curved S-shaped bone. But the most important point I want to make here, which is a frequently asked question, is its anatomy and the most common location of injury. You see, clavicle is a unique bone in the sense that the medial 2/3 is tubular and the lateral 1/3 is a flat bone. So there is a change in the geometry of the bone, and because of this change in the geometry of the bone, there is a site of vulnerability or weakness. And this is why this site of vulnerability or weakness is the most common location of clavicular fracture. Right? Why? Because the anatomy is changing. And you will come across this when we'll talk about humerus also. I'll tell you how the geometry of the bone, as it changes, introduces weakness and vulnerability. It's a very important thing that I wanted to remember. Okay, so clavicle has a unique anatomy where the medial 2/3 is tubular and lateral 1/3 is flat. That is why this point of interface is the most common location of fracture. right? And this point of interface, where does it fall? It falls in the middle 1/3 of the clavicle. If you divide the clavicle into three parts, so medial 1/3, middle 1/3, and the lateral 1/3, the middle 1/3 is where the site falls, the junction of the medial 2/3 and lateral 1/3. समझ रहे हो? Are you able to understand? This is junction of the medial 2/3 and lateral 1/3. If that is not specific enough for you, some books also say the medial 3/5 and the lateral 2/5 junction also. Okay, whatever it is, please remember it's the middle 1/3. Okay. Now, as promised, everything is written, and you can look at this slide. Horizontally arranged, ossifies in membrane, first bone to start ossifying, last bone to complete ossification, only long bone with two primary centers of ossification, curve shaped bone, flat and tubular, medial 2/3 is tubular, lateral 1/3 is flat. The most common fracture occurs at the middle 1/3 junction and medial 2/3 and lateral 1/3 junction. So, middle 1/3 or junction of the medial 2/3 and lateral 1/3, or junction of the medial 3/5 and lateral 2/5. ठीक है ना? And also remember this hashtag symbol, friends. This is a symbol for fracture. This is what we use. Okay. Apart from these things, there are very frequently asked questions about clavicle. In fact, it is the most commonly fractured bone in the body. In the human beings, it is the most commonly fractured bone, and it is also the most common bone that is fractured in newborn babies. During the birth extraction, sometimes at the time of a birth trauma or birth injury, this is the bone that is most commonly fractured. So most common fracture at the time of birth, most common fracture time of difficult birth, all right, most common fracture time of birth extraction, it is clavicle. And overall also, the most common bone to fracture is clavicle. So these are the 3 MCQs I want you to remember. Okay, coming. Now, in adults, or as in children or adults, the mechanism of injury is fall on an outstretched hand, or a direct trauma, or falling on the shoulders also sometimes. So you're walking and you fall down on your shoulder. When you fall down on the shoulder, clavicle fractures, and usually clavicle fractures. And after the clavicle fractures, the fragments displace. Right, the fragments displace. If you remember from the basics, I told you, whenever there is a fracture, because of the pull of the muscle, there will be displacement. Now, what are the displacements that you will see in the clavicle fracture? These are the displacements. The medial part of the fracture is pulled up because of the sternocleidomastoid pull, right? So, sternocleidomastoid, the cleido part of the sternocleidomastoid pulls it up. Cleido is clavicle, right? Sternocleidomastoid. And the lateral half, or the lateral part of the segment of the fracture, is pulled down. Why is it pulled down? Because of two important things. First, weight of the arm and the pectoralis pull. Now, the lateral part goes down and the medial part goes up. So whenever this patient comes to you walking, he will usually be carrying his upper limb with the other hand. Okay, because there is a fracture here. Suppose there is a fracture here, this half goes down, right? And it is painful. So what this patient does is, he will hold his elbow or his hand or his arm and then bring it up like this. And this is how we will come to your OPD. Very, very classical. Very, very classical. This is how usually comes. Why? Because it is painful because of the fracture, and he lifts it up to minimize the pain. Okay? Is that clear? Now let me show you this. Now what are the displacements? The displacements, the lateral half will go down because of the weight of the limb and the pectoralis muscle, and you can clearly see this is what is happening. This is what is happening. Let me show you the X-ray of this. Let me show you the X-ray of this clavicle fracture. Are you able to appreciate, friends? Are you able to appreciate? This is the clavicle, right? This is the beautiful clavicle, and it is fractured here. Please try to appreciate the X-rays, friends. This is what will help you score. This is what will help you score. Theory you will know. Theory you will know. You have to make the diagnosis on the exam. Now, what about the complications of this clavicle fracture? Recall, I told you the fractures that usually undergo malunion rarely undergo non-union, right? And clavicle is the fracture that most commonly undergoes malunion. The most common malunion in your body was clavicle. The beauty of this clavicle fracture is that you don't have to do much for this. Okay, because even if it malunites, there's not a lot of problem, because it's not a very, very important bone for the functioning of the upper limb. Okay, now the most common complication of clavicle fracture is malunion. Very, very important MCQs. Other complications are rare. Non-union to extremely rare, because I told you bones that undergo malunion rarely undergo non-union. And the other complication I want you to recall is, whenever there is a clavicle fracture, the neurovascular structures around its periphery will get injured, around its circumference, around its area will get injured. So what are these neurovascular structures? Can you recall from your anatomy? Batao? Brachial plexus. Yes. And subclavian vessels, yeah, they can get injured. So these are the rare complications: brachial plexus or subclavian vessels. Okay, subclavian muscle. So far so good. As promised, everything is written. You can write down and make your beautiful notes. Now tell me, what is the treatment of this clavicle fracture? Either way, it is going into malunion, and even if it malunites, there is not a lot of functional loss. So your aim for the treatment is very conservative. Just approximate the fragments so that it unites. That to just bring them close together. So what are the options you have to bring them close together? Figure of 8 bandage, arm sling or arm pouch. Figure of 8 bandage, arm sling or arm pouch. Now please understand what is the principle behind it. Figure of 8 bandage, it's in the shape of 8. That's why it's called figure of 8. Now what is its purpose? The purpose of figure of 8 bandage is to basically bring the medial fragment down. That is what it is doing. It is bringing the medial fragment down because this is the displacement. The displacement is like this. So the medial fragment is going up, right, because of the fracture. So the aim is to bring it down. So how will you bring it down? With a figure of 8 bandage. Now, what about arm sling or arm pouch? The aim of the arm sling or arm pouch is exactly the same aim as I told you in the beginning, where the patient will hold his upper limb with the other hand, right? The aim is to bring the lateral fragment up. Either you bring the medial fragment down or the lateral fragment up, so to approximate them together. So with the arm sling or arm pouch, you're bringing the lateral fragment up. I personally prefer a combination of both of them. I'll use a figure of 8 bandage and an arm sling or arm pouch. Other options available are Welpius bandage. Okay, Welpius bandage can also be used for clavicle fracture. Now, is this the only treatment? No. Sometimes the patient's clavicle fracture is associated with other injuries like neurovascular injury, or it's an open fracture, or it's causing massive displacement that might not be reduced by figure of 8 bandage or arm sling or arm pouch. Then you will have to go for surgeries. So you have to remember what are the indications for surgery in clavicular fracture and what are the devices you will use for clavicle fracture fixation. Okay, simple, straightforward indications for surgery is number 1, open clavicle fracture. Massive displacement. Sometimes the displacement is so much that they describe it in terms of tenting of the skin. They use the word tenting of the skin. Are you understanding? Tenting of the skin. It's like the skin is lifted up like a tent. Okay, such kind of displacement you need to fix because it will not reduce with just figure of 8 bandage or arm sling or arm pouch. Then a clavicle fracture involving the acromioclavicular joint. So if this joint is involved, this joint, acromioclavicular joint, if this joint, acromioclavicular joint is involved, then you will have to go for surgery. With neurovascular injury, clavicle fracture with neurovascular injury surgery, floating shoulder. Now what is floating shoulder? Floating shoulder is a fracture of the, say this is your clavicle and this is the head of the humerus, right? The floating shoulder is basically a fracture of the clavicle and the fracture of the glenoid. Now, can you imagine what happens when there is a fracture of glenoid and clavicle? This whole segment of the shoulder will be freed away from the body. It will be freed away. Look at this. So this is a clavicle fracture, and if there is a glenoid fracture, what will happen? The whole shoulder component will be free away from the body. That is called as a floating shoulder. If any of these are the case, then the treatment is surgical. But majority of time, friends, the cases do not require surgery. A few images of surgery. We use plates for fixation, or we can use intramedullary devices like rods inside. But plates, if you remember, is more than enough. But please remember, most of the clavicle fractures are managed conservatively because the healing is very good and the usual outcome is malunion. The most common complication is malunion. Okay, na? Now let's start with the shoulder joint. Now shoulder joint, if you know, is a ball and a socket joint. Ball, yes, I can see, but socket, I'm not so sure. You see, the glenoid is actually 4 times smaller than the head of the humerus, or the head of the humerus is 4 times larger than the glenoid. Obviously, you see, it's quite large. So it cannot accommodate very well. You see, and this is the reason the shoulder joint is the most commonly dislocated joint, because the stability of the shoulder joint is not mostly bony, it is mostly soft tissue. We'll talk about that. Patience. So you see, it is, although a cavity, although it's supposed to be a socket, it is not, it's flat. So what happens is, to increase the cavity or to increase the accommodation of the head of the humerus, the glenoid has a fibrocartilaginous rim all around it called labrum, the glenoid labrum, and that is what accommodates the head of the humerus. Now, you will ask me, sir, why is this joint so unstable? It's essentially by design to give you the kind of mobility that you need for the shoulder to function properly. It is the most mobile joint in the body, and if you want mobility, you will definitely have to compromise on stability, isn't it? Right? You cannot have stability and mobility together. You have to have a compromise somewhere. If you're confused, imagine yourself staying at home versus staying at hostel. Where do you have more mobility? Yes, at the hostel. And where do you have more stability? Yes, at home. Right, you understand? Excellent. Okay, so this is the shoulder joint, ball and socket joint. This is the front view, this is the back view, right? So this is the glenoid, this is the head of the humerus. What are the other parts? This is the greater tuberosity and this is the lesser tuberosity, right? This is the greater tuberosity, the point where your supraspinatus, infraspinatus, teres minor insert, and this is the lesser tuberosity where you have your subscapularis inserting, and between these two you have your bicipital groove through which the long head of tendon passes, right? So this is your shoulder joint. Now the point I'm trying to make here is that the head is 4 times larger, yes, mobile joint, therefore less stable, and it's the most commonly dislocated joint in the body. And I've told you the reason. The reason is because it's not bony stabilized, it is mostly soft tissue stabilized. So what are the soft tissue stabilizers of the shoulder joint? They are basically divided into 2 categories: dynamic and static. Dynamic are the ones that move. For example, they are muscles. The muscles that stabilize the shoulder joint are considered as the dynamic stabilizers. Now, can you tell me what are the dynamic stabilizers? The muscles around the shoulder, the rotator cuff, the supraspinatus, the infraspinatus, the teres minor, and the subscapularis, and also the long head of biceps that passes over it through the bicipital groove. Now, deltoid is plus minus stabilizer of the shoulder joint. Again, everything is written. Listen, just listen. Everything is written. Okay, ठीक है ना? Right. So these are your dynamic stabilizers of the shoulder joint. Now what about the static stabilizers? Static stabilizers, they don't move on their own. These are your capsules and the labrum that I just talked about. And there are 3 important ligaments that are attached between the head of the humerus and the glenoid. These are known as, guess it, glenohumeral ligaments. Yeah, superior, middle, inferior, right? So these are the stabilizers that I talked about: dynamic stabilizers, the rotator cuff muscles, the long head of biceps, and also deltoid. And the static stabilizers are the capsule and the labrum and the glenohumeral ligaments. There are 3: superior, middle, inferior. The most important is inferior. Okay, inferior glenohumeral ligament is the most important. Now, fun fact here: shoulder joint is stable anteriorly, is stable superiorly, is stable posteriorly, but it is weakest inferiorly. It is weakest inferiorly. There is a very, very less support inferiorly. The only thing that is there inferiorly is the inferior glenohumeral ligament, which is the most important ligament, right? And if it gets injured, it will become even more unstable. The point I'm trying to make here is that there is an MCQ here. The question is, shoulder joint most commonly dislocates where? Anteriorly, posteriorly, superiorly, or inferiorly? The most common dislocation is anterior. Please remember that. The rarest dislocation is inferior. But if they ask you, shoulder joint is weakest where? Answer is inferiorly. Inferiorly it is weakest, but dislocation is anterior. Most common. Okay? Is that clear? And that is what I have written here. Weakest inferiorly, but dislocation is the commonest anteriorly. Like I said, everything is in the PPT. I want you to listen to me. Can you do that? Right. Now let's talk about the shoulder dislocations. Shoulder dislocations, I've told you the reason. It is the most mobile joint in the body. That's why it's the least stable. That's why it's the most commonly dislocated joint in the body. In the body, it is the most commonly dislocated joint. Half of your dislocations are shoulder dislocations. Others are your elbow, your hip, your ankle, your knee, whatever. But most common is shoulder dislocation. Now, in shoulder dislocation, there are variations. There can be anterior, I told you, posterior, I told you, inferior, I told you. Superior it's not possible because you have acromion here. Unless there is an associated acromion fracture, it is not going to happen. At your level, think and superior is not possible. What is possible? Only anterior, posterior, and inferior. And the most common is anterior, right? So anterior is the most common. The most common is anterior. Now listen to me. Before we go further, I want you to understand one very important thing about dislocations. Dislocations are emergencies in orthopedics. They have to be managed emergently. And your aim is to reduce the dislocation to bring it back into the normal joint, first thing. Now, when there is a dislocation, when the dislocation is there, the limb that is dislocated will assume a characteristic attitude. Okay, now what do you mean attitude? Attitude does not mean this attitude. Attitude means the position of the limb, right? Whenever there is an anterior dislocation of the shoulder, the limb will assume a particular attitude or particular position. Why is this important? Because just by looking at the attitude of the limb, you can actually make the diagnosis, because that is how characteristic and unique it is. Okay, and that is why you have to remember it also, because that will help you make a diagnosis even before getting an X-ray. So shoulder dislocation anterior. What is the attitude? The attitude is abduction and external rotation of the shoulder. That is a very, very important attitude. Abduction Again, everything is written. I don't know why I'm writing this for you. An external rotation of the shoulder. Okay. So anterior dislocation will give you an abduction and external rotation. We'll discuss more. We'll talk about it more. But before we move further, I want to tell you what are the subtypes of anterior shoulder dislocation. There are 4 subtypes. Depending on where the head ends after the anterior shoulder dislocation, we have subclassified them. Suppose after the anterior shoulder dislocation, it ends in front of the glenoid. We call it pre-glenoid. If it settles under the coracoid after the dislocation, we call it subcoracoid. If it goes under the clavicle, we call it infraclavicular. And if it perforates the ribs and goes inside the thorax, we call it intrathoracic. These are the 4 subtypes. The most common is subcoracoid. The most common type of anterior shoulder dislocation is subcoracoid. So overall, most common is anterior. In anterior, the most common subtype is subcoracoid, meaning the head of the humerus ends up just under the coracoid after the dislocation. Okay? Is that enough? Is that clear? That you have to memorize. Now, I've already told you the attitude is abduction and external rotation. Apart from that, one important clinical feature you will notice in a patient with an anterior shoulder dislocation is that since the head of the humerus is not in its original place, can you imagine what will happen to this beautiful contour of your shoulder? It will be flattened. So there will be flattening of the shoulder contour. Look at this contour. Beautiful. Circumferential, and here what is happening? Flattening. Why is there flattening? Because the shoulder is dislocated and the skin is falling off after the acromion. So there is a flattening of the shoulder contour. Very, very important. Okay? So when a patient has a shoulder dislocation, if he walks into your OPD, he will have this classical attitude of abducted externally rotated arm, flattened shoulder contour. Now this abducted externally rotated arm can also be described as arm by the side of the body also. Arm by the side of the trunk also, which this patient has. Arm by the side of the trunk. It's abducted and externally rotated. It's arm by the side of the trunk. So write down attitude of the limb, arm by the side of the body, abducted and externally rotated. Now listen, one very important point, friends. Whenever I say there is an attitude, it automatically means the patient cannot perform the opposite action. So in shoulder dislocation, there is abduction and external rotation of the shoulder, means that it is stuck in that attitude. It means that the patient cannot perform the opposite action. Why? Because it is stuck in that attitude. So in abducted externally rotated arm, the patient will not be able to perform adduction and internal rotation. So difficulty in adduction and internal rotation is very important. It's very important because here the examiner will either tell you the attitude of the limb or he will tell you that the patient is unable to perform that action, which is the opposite of the attitude. And with this information, you will be able to make the diagnosis. ठीक है? समझ आया? Okay. Flattened shoulder contour. Those are the things that the patient will have. Now, usually, whenever a patient has a shoulder dislocation, please remember that there is a very important nerve that runs in the very close proximity of the shoulder joint. Can you tell me which nerve, with the help of your knowledge in anatomy, which nerve runs here? Which nerve runs here? I'll give you options. Sciatic nerve, femoral nerve, common peroneal nerve, or axillary nerve? Arey wah, yes. It's axillary nerve only. Yes, we know that it is axillary nerve because it runs in very close proximity to the shoulder joint, and I'll show you the image in a bit. So these patients who have a shoulder dislocation can also have associated axillary nerve injury, and I will tell you how to examine that later. Anyways, so imagine a patient coming to your OPD telling you that he has a history of fall on an outstretched hand and there is a pain in the shoulder and he's unable to adduct and internally rotate and there is a flattening of his shoulder contour. How are you going to proceed? Looking at him, his attitude, there is abduction, external rotation, flattening of the contour, there is a history of trauma. You know the diagnosis is anterior shoulder dislocation. So you need to confirm clinically and then radiologically. So clinically, there are 4 tests you should know. And again, every test is written. Just listen to me, pause the video at that slide and write down and make your amazing notes. Okay. So perform these tests and confirm your diagnosis clinically. And obviously after doing that, you will send for radiology to confirm your diagnosis radiologically. And once the diagnosis is made, then move on to the treatment. Okay, so what is the management? First, investigation and treatment. So investigation में clinical है, radiological है. Clinical investigation, what will you do? First clinical test is Hamilton ruler test. What will you do in Hamilton ruler test? Listen. It's very easy. All of these are very simple things. So you see when the shoulder dislocates, normally, if you put a scale as shown in the image, if you put a scale at the lateral condyle of the humerus and try to touch it with acromion, it will never touch because there is this head of the humerus greater tuberosity, right? Scale as shown in the image, you can see here. If you put a scale on the lateral condyle of the humerus, it will never be able to touch the acromion because there is this greater tuberosity here. But if there is a shoulder dislocation, as in the case, then what will happen? The scale will easily touch the acromion, right? Easily touch the acromion. This is known as Hamilton ruler or scales test. Okay? Now the other test is Dugas test. Normally I told you when the shoulder dislocates, the attitude is abduction and axial rotation, which means the patient cannot adduct and internally rotate. That's it. You ask the patient to adduct and touch the opposite shoulder. Basically, you don't ask him to adduct because he doesn't know what adduction is. You just tell him, Bhaiya, this is your shoulder that is dislocated, right? So you try to touch your opposite shoulder. He will be unable to because he cannot adduct and internally rotate. Because to touch the opposite shoulder, you need to adduct and internally rotate. He cannot do that because the shoulder is stuck in abduction axial rotation. This test is known as Dugas test. Okay. Then there is something known as Callaway's test. Callaway's test and Bryant's test are similar in a way where, because in Callaway's test, what happened? The shoulder dislocates, right? When the shoulder dislocates anteriorly, what happens? The circumference or the girth of the shoulder will increase, right? If you measure the circumference or the girth of the shoulder, because the head of the humerus is dislocated anteriorly, what will happen? The girth measured will be increased. Increase in the girth. Imagine it. Girth. Okay. And what is Bryant's test finally? Bryant's test is when the shoulder dislocates, and because of the shoulder dislocation, the axillary fold will be at a lower level. This is the axillary fold, which is at the lower level compared to normal. That's it. These are the tests, and everything is written here. You can pause this video and make your beautiful, amazing notes. The Hamilton ruler test, Dugas test, Callaway's test, and Bryant's test. Now, I also told you that whenever you have a shoulder dislocation, there is a high chance of injury to the nerve. Which nerve? And you answered very well. Yes, axillary nerve. So axillary nerve will injure. You can look at this clearly. It is a nerve that runs in very close proximity to the shoulder joint, and it invariably gets injured in shoulder dislocation. But also another important point I want you to make here is, and write down if you can, is that axillary nerve is actually quite well protected. It's inside the axilla, right? Well protected. So there is not a lot of things that can injure it. One is shoulder dislocation, very important cause. Another is proximal humerus fractures. Proximal humerus fractures. So also remember, in proximal humerus fractures, axillary nerve will get injured. So these two things I want you to remember. Now, if a patient has axillary nerve injury, what will be his presentation? How will you assess it? If you remember reading from nerve injuries, whenever there is a nerve injury, you want to assess the sensory component or the motor component. If it's a mixed nerve, you want to assess the sensory and the motor component. Motor component of axillary nerve is, if you recall, deltoid and teres minor, right? You remember this from our basics, anatomy, right? Deltoid and teres minor. We cannot test this because the shoulder is dislocated. So it is already stuck in abduction axial rotation. You cannot test this. So what are you going to test? You're going to test the sensory component. So what is the sensory distribution of the axillary nerve? This part, the upper lateral half, the upper lateral part of the arm. This is known as the regimental badge area, because this is where you put the badges in regiments and army and police, right? And if there is axillary nerve injury, the patient will have paresthesia and tingling and numbness in this area. So this is known as regimental badge sign. So if a patient comes to you with a shoulder dislocation, he will have an attitude of abduction axial rotation, and if you put your finger and test for sensation, he will say no sensation or paresthesia. So you can immediately say that this is a patient with a shoulder dislocation with axillary nerve injury. Okay, so these are all the clinical tests that we'll perform. Okay, so deltoid and teres minor are the motor distribution, which we cannot test because the shoulder is already stuck, and so regimental badge area is what you will test, that you can write down. So you again, this is clinical diagnosis. Now what about radiological diagnosis? In this era of medical legal cases and lawsuits, you should be very careful. You have to confirm your diagnosis radiologically. What will you use? X-rays. What are the views? You will take AP and lateral or axillary views also, and you will look for the dislocation. Here you can clearly see it's an AP view. This is the glenoid, and the head of the humerus is not sitting comfortably in the glenoid. It is dislocated. It's clearly dislocated, and this is how you make the diagnosis. In lateral view, you will notice that it is anteriorly dislocated. That's it. You have made the diagnosis. You have made the clinical diagnosis, and now you have confirmed it radiologically with the radiological diagnosis. What is the next step? The next step is to treat it. Any dislocation I told you is an emergency, reduce it as soon as possible. Now, how will you reduce it? There are plethora of techniques of reduction for any dislocation. So shoulder is no exception. There will be many techniques of reduction. How will you reduce? One very important technique you have to remember for your exam. And this is something that is commonly performed in day-to-day practice. Modified Cocker's technique. Okay, so what do you do in this technique? You make the patient who has the dislocation either sit or lie down. usually preferably sitting, and his shoulder will already be stuck in abduction external rotation. In whatever deformed position it is, you just first apply traction. Okay, apply traction, and then you start external rotation. Slowly you start adducting, and then you go for medial or internal rotation. Right? So first you apply traction, external rotation, then adduction. So look at this image. I'll show you the image step by step. Look at A, is applying traction, then external rotation, then adduction, and then medial rotation. So traction, external rotation, adduction, medial rotation are the steps performed. And if you want to remember it, this is the mnemonic team. This will help you remember it. So these are the techniques. This is the technique of shoulder reduction known as modified Cocker's technique, and this is the steps. There was an INI set question where they asked the sequence of reduction technique. So this is what you will do. Most commonly performed technique. Any other technique that you should know? Yes, two more. One is Stimson's technique. What do you do in Stimson's technique? You basically you hang a heavy object. You tie a heavy object around 10 to 15 pounds to the limb that is dislocated, and then you hang the limb that is dislocated and keep the patient like that for some 15 to 20 minutes. Over time, because of the pull, the shoulder will relocate. This is known as Stimson's technique. Okay. Another technique, Hippocrates technique. Look at what he's doing. He's put his foot in the man's axilla and he's using the axilla as a fulcrum to reduce the shoulder joint. Can you imagine doing this? No. That is why we do not prefer this. It's not preferred. It's old, outdated technique. Look at how gross it is, right? We'll not prefer that. So those are the techniques of reduction. So names, you need to know: modified Cocker's, Stimson's, and Hippocrates technique. Okay? Right. Now coming to the complications and the lesions associated with shoulder dislocation. Two very important ones that will be asked on your exam is Bankart lesion and Hill-Sachs lesion, and I will clear it once and for all to you today what it is. So first of all, what is Bankart lesion, friends? What is Bankart lesion? So again, look at this, the anterior aspect. Shoulder dislocates anteriorly. Shoulder dislocates anteriorly. And I've told you, shoulder joint is a very unstable joint. Basically, it is stabilized by the soft tissue. So whenever there is a shoulder dislocation, invariably there will be a soft tissue injury. So what is the soft tissue that gets injured whenever there is a shoulder dislocation? The glenoid labrum, right? The glenoid labrum that is surrounding. So when there is a shoulder dislocation anteriorly, which part of the glenoid labrum will get injured? That is the question. It is the antero-inferior part. So look at this. I'm showing it to you from lateral side. Shoulder dislocates anteriorly. And when it dislocates anteriorly, which part will get injured? Antero-inferior part. So look at this diagram. Head, glenoid labrum gets injured here. Antero-inferior part of the glenoid. This is known as Bankart lesion. So if it's only the glenoid labrum, it is Bankart lesion. It is the most common lesion associated with shoulder dislocation. Now, rarely, very rarely, as the glenoid labrum is getting avulsed, it takes a small chunk of bone of the glenoid with it. It takes a small chunk of bone of glenoid with it. This is known as bony Bankart. This is known as bony Bankart. Which is more common? Bankart lesion is the most common. Bony Bankart is quite rare. Quite rare. Sometimes they ask you, what is attached to this antero-inferior part of the glenoid labrum? It is the inferior glenohumeral ligament, the most important or the principal stabilizer of the shoulder. So if you have a Bankart lesion that has occurred because of the shoulder dislocation, it invariably means that IGHL, that is inferior glenohumeral ligament, is also injured, which means that the principal stabilizer is injured, which means the shoulder will go into further instability, right? Keep that in mind. We'll discuss in the MCQs. Next, let me show you a 3D CT reconstruction of a bony Bankart lesion. Can you see this? So this is the anterior part of the glenoid. This is the posterior aspect. This is superior aspect. Look at this part, the antero-inferior part of the glenoid labrum and a bony chunk. This is your bony Bankart lesion on 3D CT reconstruction. On X-ray also you can see a small chunk of bone here, right? That is the attachment of the inferior glenohumeral ligament. This is your Bankart lesion. This is your bony Bankart lesion. Okay? Understood? Where does it occur? Antero-inferior part of the glenoid. Antero-inferior part of the glenoid. Antero-inferior part of the glenoid. It can be soft tissue, most common, very rarely bony Bankart. Right. The second lesion I want you to remember is Hill-Sachs lesion. What is Hill-Sachs lesion? What is Hill-Sachs lesion? First thing, Hill-Sachs lesion, H for Hill-Sachs, occurs on the head of the humerus. Now, see, if you have a shoulder dislocation, right? If you have an anterior shoulder dislocation, shoulder gets dislocated anteriorly, right? Now, after dislocation, imagine if it comes back and hits the anterior rim or the surface of the glenoid. What will happen? This glenoid labrum or the glenoid will hit the head of the humerus. Where? On the posterior lateral aspect. And imagine if this happens again and again and again and again frequently. If a patient has a recurrent shoulder dislocation, there will be an indentation or an excavation or a deep excavation on the posterior lateral aspect of the head of the humerus. Can you imagine this? Can you appreciate this? The head of the humerus is dislocating. As it is dislocating, it comes back and it gets hit on by the anterior surface of the glenoid, and there will be an indentation and excavation or a deep excavation here. This is known as your Hill-Sachs lesion. Let me show you an X-ray. Can you see this deep excavation or indentation on the posterior lateral aspect of the head of the humerus? This is Hill-Sachs lesion. This is Hill-Sachs lesion. Not as common as Bankart lesion. Bankart more common. This is Hill-Sachs lesion. Okay. Can you remember these two lesions for me? Everything I said is written here. Most common lesion associated with shoulder dislocation is Bankart. It is usually a soft tissue Bankart or sometimes bony Bankart. It's a version of the labrum at the anterior inferior glenoid rim. Hill-Sachs lesion, it's a defect or excavation on the posterior lateral surface of the humeral head due to repeated impact against the anterior glenoid rim. Okay. Everything I have said, I have explained. Now a few MCQs. What is the most common complication of shoulder dislocation? The most common complication of shoulder dislocation is recurrent shoulder dislocation, because even one dislocation can injure the soft tissue stabilizers. So there will be recurrent dislocation. Okay. Second MCQ. What is the most common early complication of shoulder dislocation? The most common early complication of shoulder dislocation is axillary nerve injury. Third MCQ. What is the most common late complication of shoulder dislocation? It is recurrent shoulder dislocation. And fourth and last MCQ I want to discuss, what is the most commonly injured nerve in shoulder dislocation? The answer is axillary nerve. Okay, as promised, everything is written here. You can write down. Now, extra set of MCQs. Quick review also. What is the most common type of shoulder dislocation? Anterior. Very good. Most common subtype of anterior shoulder dislocation? Subcoracoid. Yes. Shoulder joint is weakest where? Inferior. Very good. And the rarest type of shoulder dislocation is inferior. Okay? Rarest type is inferior. 4 extra MCQs that you can write down. So that completes our anterior shoulder dislocation. Moving on to posterior shoulder dislocation. Now, posterior dislocation is actually quite literally the opposite of anterior shoulder dislocation. Here, the head of the humerus goes posteriorly. Again, the mechanism of injury can be fall on an outstretched hand, but here there is a unique mechanism. There is a high voltage electric shock. Okay, as in your body shaking vigorously, high voltage electric shock, or electroconvulsive therapy or post-electroconvulsive therapy that you give to psychiatric patients or seizures patients. Post-seizure patients. So please remember, if on the MCQ exam, the question mentions seizures, a patient on treatment of seizures or patient under electroconvulsive therapy, remember it is usually posterior dislocation. Just keep that in mind. I'll show you how. Now, what happens to the attitude of the shoulder? Exactly the opposite. In anterior dislocation, it was abduction, axial rotation. Here it will be adduction and internal rotation. And very importantly, the contour of the shoulder is not lost here. And that is why it usually is missed. There are two important reasons why it is missed. First is that these patients who have seizures or these patients who have high voltage electrical shocks, they don't remember what has hit them. Seizure patient doesn't remember he had seizures, right? So he will have seizures, then he'll come to you. And when he's brought to you, he will complain of shoulder pain. And apart from complaining of shoulder pain, he will tell you one classical point. He'll tell you, sir, I cannot move my shoulder properly. And if you notice, he will be unable to abduct and externally rotate, which is the limitation that you will see in posterior dislocation, because the attitude of posterior dislocation is adduction and internal rotation. And I've told you, if this is the attitude, what action can the patient not perform? The patient will be unable to perform abduction and external rotation. So the examiner will tell you, is a seizures patient on treatment, probably missed the treatment for a few days, comes to you with shoulder pain, with difficulty in abduction. What is your likely diagnosis? Okay? Are you understanding how this game is played now? Right. Shoulder contour is usually maintained, and that is why this is very commonly missed. This is missed. And another reason why it is missed is X-ray also. See, this is normal shoulder. If there is a posterior dislocation, I've told you there will be adduction and internal rotation. So this is how the shoulder will be. This is how the shoulder will be on X-ray. And for an untrained eye, the head is still in the glenoid. It will look like that. But if you look very carefully, it will not be in the normal shape. It will be in the shape of a light bulb or electric bulb. And that is why this is known as the light bulb sign or electric bulb sign seen in posterior dislocation of shoulder. Very, very important. Very, very important. Now, can you imagine what type of Bankart and Hill-Sachs lesions these patients will get? Yes. So they will get reverse Bankart or reverse Hill-Sachs lesion. So what is reverse Bankart? Head of the humerus going posteriorly, right? It's going posteriorly. So which part of the glenoid labrum will get injured? Posterior, inferior part. Very good. And if it's dislocated, the head of the humerus will come back and hit the posterior glenoid rim. Which part of the head of the humerus will hit it? Anteromedial part. Which part will hit? Anteromedial part. So what is reverse Bankart and reverse Hill-Sachs? Reverse Bankart is posterior inferior part of the glenoid rim, and reverse Hill-Sachs is anteromedial aspect of the head of the humerus. Okay, na? You're able to appreciate now. That is more important. But please see this. There will be many facts that you will come across to remember and recall. But you should not remember remote facts. You should not remember the facts that are very rarely asked. Here, Bankart's lesion and Hill-Sachs lesion is very commonly asked. Reverse Bankart, reverse Hill-Sachs, very rarely asked. So do not try to remember reverse Bankart and reverse Hill-Sachs at the cost of forgetting Bankart and Hill-Sachs. So what is frequently asked, you should know. Okay? Right. So that is everything about posterior dislocation, electric convulsive therapy, seizures, patients, and the attitude. Now, lastly, inferior dislocation, the rarest of rare dislocation, also known as luxatio erecta. So what is the mechanism of injury? Falling down. When you're falling down, you hold on to an object, and when you hold on to an object, it goes into hyperabduction. And this hyperabduction injury gives you a classical attitude known as luxatio erecta, because it looks like the upper limb is in erection, or the arm is by the side of your head. Arm is by the side of your head. Right? So this is the inferior dislocation. Okay. Again, you can clearly see on X-ray, the head is inferior and there is arm by the side of the head. Now, the last thing that I want to discuss here is shoulder instability. See, whenever there is a dislocation, I've told you there is a soft tissue injury which will make the shoulder even more unstable, making it recurrently dislocate. So what are the tests for instability of the shoulder? Sometimes they ask you this. So these are the tests. For anterior instability, you have fulcrum test, you have crank test, and you have apprehension test. For posterior instability, you have jerk test, and for inferior instability, you have sulcus test. There is nothing to understand here. These are the names of the test. You just need to know the names. That is enough for your exam. Now, the last thing, this is an extra point that I would like to add here, is a long time ago, they used to ask this question, and none of these surgeries are performed, but you should know for the sake of your old MCQs. What are the surgeries that you will perform for shoulder instability? There are two surgeries. One is putti-plat operation, other is Bristow-Latarjet operation. Let me just tell you what putti-plat operation is. Putti-plat operation, you take the capsule that is anterior and the subscapularis muscle that is anterior, make an incision and overlap them, as in double breast them and suture them. So what will happen when you overlap or double breast them? The shoulder will go into internal rotation. When the shoulder goes into internal rotation, it cannot be externally rotated. And if it is not externally rotated, it will not recurrently dislocate. So that is a very aggressive surgery known as putti-plat operation. Second is Bristow-Latarjet operation. In Bristow-Latarjet operation, what you do is you osteotomize, mean cut the bone. You osteotomize the coracoid. Once you've osteotomized the coracoid, you remove that chunk of bone and place it in front of the glenoid, preventing the shoulder from dislocating anteriorly. Again, very aggressive procedure. Okay, this is known as Bristow-Latarjet procedure. But nowadays, we are going for arthroscopic Bankart and Hill-Sachs surgeries, which are much more reasonable and are giving much more better results compared to these aggressive surgeries. So that is all about your shoulder dislocations.